Now let's talk about these different parts one by one. So like I said, we need to extract four different kinds of information, right? The first part is bibliographic information. So the most commonly extracted data is first author's surname. For example, for me, it's Yang. Okay, Joy Yang. So you need to extract my surname, Yang, and publication year. In which year was the paper published? Maybe 2019 or 2015, right? So sometimes, for your own convenience, you may also extract the journal in which the paper was published, and maybe title of article, or sometimes you may extract the acronym of the study or project's name. So many clinical trials or many large cohort studies, they will assign a so-called acronym of the project's name, like HEART. Okay, so HEART, HEART, these 5 letters may come from the capital letters, the initials of the full name of the project, right? So they call it HEART, something like that. Okay, and people use this kind of names to refer to a very famous study easily, okay, for easy reference. But in most cases, the first 2 is enough. First author's surname and publication year. And this information will be used as an identifier of the study in your systematic review report. For example, later, I will give you some exercise. So one of the paper is published by Orkin and colleagues in 2025, right? So this paper is referred to as Orkin 2005. So in your systematic review, you can when you talk about this paper, you can refer it in this way. Okay, Orkin 2005. And the second use of this information is for like results presentation and also data verification. So this is convenient for yourself when you are doing like data analysis or even like report writing or anything else. Okay, and when you want to go back to this paper to check something, you can identify this paper easily, right? This it seems very, this is very obvious, right? But actually many beginners don't know how to do it. I remember last year, one master student I supervised, so she also did a systematic review, and I think more than 50 papers were included in her systematic review. And when he sent a large file containing all the eligible studies to me, I found that, the title of every file she used is the full title of the paper, a very long title. Now, I told her, well, this is hard to read and also hard to identify. And in fact, she herself cannot find out which paper she's talking about, okay? So we're talking about this paper, there seems to be a problem. And I asked her, you should tell me which paper is this one? And send me that paper directly. And she cannot find out that paper. Because, the title of all these papers are the full title, right? It's not the unique features of the paper. So even for yourself, it is not convenient. So that's why you are strongly recommended to use the surname and publication year as the ID. And the second part of the information that you need to extract is PICOs. PICOs, as I introduced in previous sections, is participants or patients, intervention, control, outcome, and setting. Okay, so what are these information used for? First use is to determine the generalizability of results, because basically PICOs describe the scope of the study. For example, the participants or patients, if your study is focused on like the very elderly people aged more than 70 years, so that means the results of the whole system review is mainly generalizable to the very elderly people, right? But for the young patients, maybe it's not generalizable, not applicable, right? Or maybe if the IC, intervention and control, if you are comparing like comparing the drug a certain drug at the dosage of 50 milligram per day versus control, then the generalizability will be about this dosage, right? You cannot make any inference about the dosage of 100 milligram or 200 milligram per day, right? And also setting. Is the studies conducted in like resource-limited countries, such as African countries, or were they conducted in like developed countries, like in European or in the United States, right? So different scenarios, the generalizability will be different. Okay, the first use of PICOs is generalizability. Second use is to, you may use these features to explore the potential source of heterogeneity through subgroup analysis or in the discussion part, okay? So for example, if you observe significant heterogeneity among studies when you are doing meta-analysis, then the next step you want to do is to, like, you may do some subgroup analysis or even meta-regression to find out the potential factors, right? But what factors do you include in the subgroup analysis or meta-regression? So you may include some factors about patients' characteristics. For example, the age range, right? Or the severity of disease, or the dosage of treatment. You may do subgroup analysis according to those factors. Okay, so for that purpose, you need to extract the information here. So these are the two uses of PICO's information. Now, the first element, P, participants or patients. What kind of information should you extract for participants? Let me give you some examples, okay? So the general principle is that you should look at the information, the characteristics that may affect treatment efficacy or prognosis of patients. That's relevant to the outcome, to the final outcome, right? Otherwise, it's not relevant and you don't need to extract this information. For example, age, sex composition, for example, the percentage of male or female, okay, either one is okay. And sometimes ethnicity. Because the efficacy of some drugs may differ, may vary with race or ethnicity, okay? For example, the targeted therapy for non-small cell lung cancer. Okay, the efficacy of that drug actually varies with ethnicity. It's more effective in Asian people, but less effective in European people, something like that. Okay, sometimes you may also be interested in smoking, drinking status, severity of disease, performance status in cancer patients, social demographic features, and maybe even genetic features or previous treatment they have received. Okay, so now here I want to emphasize is that this list of variables always depends on your objective, your topic. You always need to tailor the list according to your topic. For different topics, they are different, okay? Now, for example, if your topic is about lung cancer, of course, smoking status at baseline is very important, right? How many of these participants are smokers and how many of them that are non-smokers, right? And for, like, if you're looking at cancer, then you will need to look at the stage or severity of disease. So for cancer, we know we have stage 1, stage 2, stage 3, and stage 4. Okay, stage 1 is the mildest disease, right? Maybe it's local disease, but stage 4 means that there is metastasis. The cancer has spread to other parts of the body, to other organs. It's really the severe stage, right? And you may also, for cancer patients, you also need to look at the so-called performance status, okay? But if you're looking at diabetes, you're focused on diabetes treatment, then smoking status, maybe it's not relevant. Ethnicity, maybe it's not relevant, right? Performance status, also not relevant. But instead, you may need to extract some information about the duration of diabetes. You know, in many RCT, when the patients enter the RCT, they actually have been diagnosed with diabetes for more than 5 years or even 10 years. Okay, and that duration of disease will actually affect the efficacy of the drug. So the longer the duration of disease, the less, I mean, in theory, the longer the duration, the less effective the drug will be. Okay, so that's why the information is important and you should extract them, right? So the principle is that first, depends on your topic, you need to tailor the list of variables. Second, you only need to focus on the factors that may affect treatment efficacy or prognosis. If they are unlikely to affect these outcomes, you don't need to extract them, okay? And for intervention or treatment, you will need to, the general principle is also the same. Focus on the information, the data that may affect prognosis of patients, evaluation of treatment efficacy, or implementation of the intervention. Let me give some examples. If you are looking at the drug, okay, or a certain category of drug, then you will need to write down the name of the drug. Maybe you are looking at a whole category of drug, and there are several different drugs under the category, right? So in different studies, maybe they are investigating the efficacy of different drugs. So when you're doing data extraction, write down the name of drug. And also for exercise, later I'll give an example, okay? For exercise, you need to write down the name of exercise or diets, okay? We have like DASH diets, we have FODMAP diets, etc. Different diets, right? What kind of diets you are actually looking at, okay? And also the detailed components of intervention or comparison. For example, when you are evaluating the efficacy of a certain drug, there could be different comparisons. Some studies, some RCTs, they may evaluate the drug alone versus placebo alone, right? Drug alone versus placebo alone. But sometimes they may evaluate the new drug on top of standard care versus standard care alone. Or they may evaluate drug A versus drug B versus drug B alone, okay? So all these comparisons, the net comparison is the same, drug A versus placebo or nothing, right? But the detailed comparison is different. And these details may actually affect the final efficacy of the drug, okay? And for some other interventions, such as health education, you also need to write down what are the contents of health education. Because health education is a very general, broad term, right? So what kind of information are you delivering in the health education session? So are you talking about the healthy diet or exercise or some like behavioral intervention, something like that, right? So you need to write down. And so for drugs or exercises, you will need to write down the dosage and intensity as well. The dosage, for example, 50 milligrams per day, right? And intensity, for example, if you're talking about exercise, then what is the target of exercise? You need to achieve, you want to achieve a target heart rate of like 100 per minute or 120 per minute. So that's the target, right? So, and that's an indicator of the intensity of the exercise, okay? And also frequency. How many times per day or per week or per month? So depending on the nature of the intervention. If it's for drug, maybe you need to write out the times frequency per day, okay? If it's for other like health education, maybe you need to write out the frequency per week, something like that. And also the length, the total duration of intervention period, okay? For you will give the intervention to the patients for a total of 1 month or 2 months or 6 months, right? So all these are the details of the intervention, the contents of intervention. But sometimes you may also need to extract the details about the delivery of intervention. How was the intervention delivered? For example, was it delivered by trained implementers, by experts, okay, or delivered by some like very general people in the routine settings, etc. And also, you may look at the participant responsiveness. So some studies may report the response rate. So how many participants actually respond to the intervention or attend the training sessions, etc. Right? So again, the list of variables need to be tailored according to your very specific topic, your objective. You don't need to extract all these details for every systemic review, okay? But these are the general things that you need to consider. So it's you, the reviewer, the experts, who decide which to extract and which to just ignore, okay? And the third component is control. For this part, it's very similar to intervention. So if the control group received an active intervention or standard of care or existing active treatments, then the variables to be extracted are similar to those for intervention groups. Okay, so for the intervention group, it's a new intervention, right? But for this one, it's an standard treatment, another active treatment. So the variables to be extracted will be the same. But if the control group received no treatment or simply placebo, that will be much easier. You just need to write out the name. Oh, it's usual care, or it's like placebo, something like that is enough, right? So this part is relatively easy. The fourth part is outcome. Okay, for outcome, there are several issues that you need to consider. You need to consider these issues mainly because they are related to the accuracy of information. Okay, if you don't write this information down, maybe it will be difficult for you to determine whether the data is accurate or not, whether the data is comparable to other studies or not. Okay, first thing is the name of the outcome. Name of the outcome. Now, for example, maybe the outcome events you are interested in is stroke. Then you need to specify what kind of stroke. Is it incident stroke? Is the first occurrence of stroke, first attack, or does it also include second attack or third attack? Because you know, heart disease, heart attack, and also stroke, they may occur for multiple times, right? Are you looking at the first time or second time or third time? Another example is for mortality. Sometimes maybe you want to evaluate the effectiveness of a certain surgery, okay? Surgery. So, you know, for surgery, sometimes patients may die within just 1 month of the surgery. And that kind of death is called surgical related mortality. So very often we will consider that, oh, this death is potentially caused by surgery. Without the surgery, they will not die, right? So are you looking at the surgery mortality, or are you looking at the mortality in the long term, within 1 year or 3 years? They are different, right? And they mean different things. So something like that, the name of the outcome or the nature of the outcome. Second is the method of ascertainment. How was the outcome ascertained in the primary studies? So were they self-reported by the patients or their family members, or did the authors and investigators link to some registry or medical records? So different ways of ascertainment means different accuracy of data. So if the data was self-reported by patients, I mean, in theory, it's less accurate, right? But if the data was ascertained through medical records or some death or cancer registry, or maybe even the occurrence of the outcome was ascertained by a special group of doctors, well, that will be very accurate, right? So this issue is related to accuracy. That's why you should consider extracting this data. Okay. And for some outcomes, you may also need to write down the diagnostic criteria. For example, if the outcome of your interest is the incidence of diabetes, then you need to write down the diagnostic criteria. Because we have different criteria for diagnosing diabetes. We have so-called fasting plasma glucose. We have HbA1c, okay? We have the 2-hour post-challenge glucose, etc. There are 3 different biomarkers. Which one are you talking about, right? Or was the diagnosis solely based on clinical symptoms? Okay, something like that. So this is the diagnostic criteria of outcomes. So for cancer, if you are evaluating the efficacy of a certain drug treatment for cancer, then maybe you will need to write down the so-called response criteria, the criteria for determining whether a patient responds to that treatment or not. We have WHO criteria, we have the US CDC criteria, etc. Okay, and the fourth thing is called timing, time frame. So are you interested in the outcome that occurred within 6 months post-intervention, or within 1 year post-intervention, or within 24 months? So later in the tutorial exercise, the examples I give to you is about the CD4 cell account in HIV/AIDS patients. So different papers, they recorded the outcome occurrence in different time frame. Okay, so you will need to write down the time frame and also unit. So for some outcomes, for example, blood glucose, different people, different researchers may express it, may measure the outcome in different units. So some people may say, oh, it's 7.0 per millimole, 7.0 millimole per liter. But other people may say, oh, it's 126 milligram per deciliter. Okay, so these 2 units, they can be transformed to each other using some formula. Okay, so you need to write out the unit reported in the primary studies. Just in so otherwise, you can combine the data directly, right? Because the same number in different studies, they mean different things. You cannot just combine them by meta-analysis. You need to do the transformation first, right? To make the units consistent across the studies. And the last thing is, for scales, sometimes different people may measure the same thing using different scales. In this case, you need to write out the name of the scale and the possible range of the scores. Now, let's say for quality of life, there are 5 or 6 different scales. We have so-called SF36, we have SF12, something like that. And for each different scale, the highest possible score is different. So for SF36, maybe the highest possible score is 36. But for SF12, maybe the highest possible score is 12. So the one unit for different scales means different things, right? So you need to write down the upper and lower limits of the scales, and whether a higher score represents a better outcome or a poorer outcome, right? For example, if you're doing an assessment of depression, you use a so-called depression scale. So for that scale, maybe the higher the score, the severe the disease, you're more likely to have depression, right? Different scales have different meanings. So this is for the outcome. You need to consider these aspects. The last part is setting. Okay. Some system reviews, setting is relevant. Okay, they are interested in the setting, but some system reviews is not relevant. Okay. Now let's say you are interested in the setting. So what kind of information you need to extract? In general, you may write down the data about geographical location. For example, which country? Okay, so some intervention, they are like country specific, right? The country specific. And also you may need to extract the data about facilities, the facilities where the intervention or healthcare is provided. Later, I will give an example about exercise. Okay, those exercises were delivered, they were conducted in different settings, different facilities. And sometimes you may need to extract the data about study period, because study period may actually relate it to the efficacy of treatment. Now, for example, if you are looking at the efficacy of stent, 支架, so this is used for the patients with heart disease. Okay, so but there are different types of stent. So some are drug-eluting stent. That means on the surface of the stent, they apply some drug. Okay, but some of them, the stents are bare metal, nothing, just the metal stent. So different types of stents, their efficacy could be different, right? Maybe in the old days we only have bare metal stent. So the efficacy mainly comes from the physical effect. You use the stent to revascularize the patients, right? But later we also have drug-eluting stents, which can prevent some complications to occur in your heart, in the artery, right? So their efficacy could be different. And this is related to the study period. In the old days, maybe the efficacy is poorer, but in the more recent years, it's better. Okay, so really depends on your study topic. Okay, so this is all the information about P codes that you may want to extract from the papers. The third part of information that you need to extract is methodological quality, or sometimes we also call it risk of bias assessment. Okay, so you need to focus on the methods section of the paper and extract some details. For RCT and observational studies like cohort studies, the details need to be extracted are different. So let me take RCT for example. So you need to extract data on the random sequence generation. How was the random number or random sequence generated? Was it generated by a computer, or did the authors use some random sequence, from a statistics textbook, right? Or was it produced in other ways? You need to write down. But some people didn't do the randomization properly, okay? Or sometimes they may not mention anything about random sequence. So if they didn't report anything about that, you also need to write down, not report it, okay? Because all these tests will be used as the basis for your judgment, whether this is a high quality study or low quality study. Okay, so similarly for other domains, for example, was there blinding of participants, blinding of outcome assessors, or selective reporting, etc. And this will be discussed in more detail next session. Next session is about quality assessment. Okay, so I will give you some examples about how an RCT paper is evaluated and how a cohort study paper is evaluated. I will give you more details about that. Okay, so for this session, you only need to know that, you need to extract some data covering different aspects of the study. So what is this kind of information used for? First, it can be used in the data analysis. So you may do some sensitivity analysis according to the features. For example, based on this information, you will assess, or you will consider a study as high quality or low quality, right? Then in the data analysis, you can divide the studies into two groups, high quality groups and low quality groups. And you may either exclude the low quality studies in sensitivity analysis, or you can also do a subgroup analysis. Okay, there are two subgroups. One is high quality, one is low quality, and you compare the results of the two groups, and see whether they are different or not. So this is the first use of this kind of information. And the second use is to appraise the overall quality of evidence according to the grade framework. So nowadays, many people would assess the overall quality according to the theory of grade. Okay, you can Google search what grade is. Okay, but very often people will just discuss the quality of evidence in the paper in the discussion section. So they don't do the appraisal, the overall appraisal according to grade. They just mention this issue in the discussion part, and they will do a sort of qualitative assessment of the evidence, and based on the assessment, they will draw a conclusion. Okay, whether the evidence summarized in the systematic review is reliable or not, whether it's like moderate quality or high quality. Okay, and then based on this, they will say something about about the strength of their conclusion. Okay, whether it's highly recommended to give this treatment or whether it's not highly recommended, something like that. So what I want to I would like to let you know is that all this information, they are useful. Okay, you don't extract this data just for fun. Okay, they are actually very useful in the later analysis or in the later report writing. Now, the fourth part of information that you need to extract is the results. Like I mentioned earlier, it's mainly about the numbers, right? The numbers that can be used to assess the efficacy of intervention or the strength of association. Okay, so in this part, our focus is on the effect estimate and also their 95% CI. So for different types of outcomes, the effect estimate is different. If the outcome of your interest is dichotomous outcome, for example, with or without the disease, so you're looking at the instance of a certain disease. Some people develop the disease, other people do not develop the disease, right? So it's only yes or no. The answer is yes or no, or presence or absence of disease. So this is so-called dichotomous outcome. For this type of outcome, the most commonly used effect measure is risk ratio or odds ratio. Okay, these two are most commonly used. Occasionally, we will also look at the risk evidence on top of risk ratio or odds ratio. Okay, these two, they are essential. You can use either one. And if the outcome is a continuous variable, let's say blood pressure, okay, you want to evaluate the efficacy of a drug, of a blood pressure lowering drug. And one of the outcomes you are interested in is blood pressure, okay? How much the blood pressure is reduced by the drug, maybe 10 millimeter of mercury or 20 millimeter of mercury, something like that. So, and that will be a continuous outcome. And also, if you're looking at like quality of life scales, you have different scores, right? 20 marks or 25 marks, something like that. It's also a continuous outcome. So for this continuous outcome, the effect measure will be mean difference. Okay, you have a mean in the intervention group. You also have a mean in the control group, and the final, the ultimate effect measure is the difference of mean between the two groups, which is so-called mean difference. And the third type is time to event outcome. For example, overall survival time. And this is very often used in cancer, in oncology studies. Like if you are evaluating the efficacy of drugs for treating cancer, they will look at the survival time or the time from treatment to progression of disease, which is so-called progression-free survival time. Okay, so for how long the patients are free of the cancer, and then they will progress, right? So something like that. This is a period of time, and it's called time to event outcome. For this type of outcome, you will need to use hazard ratio. Okay, so basically there are three general categories of outcomes: dichotomous, continuous, and time to event. And they use different effect estimates